Hello everyone, welcome to sqadia.com. This is Dr. Sana Khan with the General Surgery course. Today we'll be talking about breast cancer surgery. In the previous couple of lectures, we have been discussing about the different pathologies which are related to the breast, like we talk about the benign and the malignant disorders as well, and some fibrocystic diseases in the old lecture. But today we will just give a short overview of the diseases, and then we'll be talking in detail about the surgical options and the techniques for the breast surgery, for even the complete radical mastectomies, and also we're going to talk about some breast conservation surgeries and how the breast reconstruction would be created. So let's have the outline for the little bit about the anatomy of the breast. So we know actually that breast is a modified sweat gland, and it's if we talk about the position of the breast, so it's extending from second to the sixth rib, and medially obviously we have the medial wall, which is obviously the sternum. And if we talk about the lateral edge of the breast, so it's some part of the breast in the form of the axillary tail is going deep into the axilla. So the lateral boundary is actually made by the axilla, and when we talk about the most posterior wall of the axilla, so that would be obviously the latissimus dorsi muscle. Now, when you talk about the anatomy and when you talk about the blood supply, so we know that most of the time the branches of the internal mammary artery, which are also called as the internal thoracic artery, they actually supply the breast. And when you talk about the lymphatic drainage, so most of the time it's draining into the sentinel nodes. When you talk about a sentinel node, that typically means a node in which the first the lymph node in which there would be first drainage of the lymph. So that would be a sentinel node, and that would go all the way to the nodes in the axilla, like the interaxillary groups, and then it goes all the way to the supraclavicular nodes. So we have some levels of the nodes. When you talk about the breast, they're level 1, level 2, and level 3. So what is the demarcation for these lymph nodes? So we actually divide them on the basis of the pectoralis minor muscle. So the lymph nodes which are more lateral and below, okay? So they are the level 1 lymph nodes. And level 2 lymph nodes are those which are behind the pec minor muscle. And level 3 lymph nodes, they are above and more medial to the pectoralis minor muscle. So why this demarcation is important? Because when you do the mastectomy and you combine it with axillary clearance, because most of the time the infiltrating cancers, they have a lymphatic spread as well. And it goes to the sentinel nodes and the axillary nodes, and then maybe extended to the supraclavicular nodes. So what happens is like you have to do the axillary clearance, which is axillary clearance level 1 or level 2 and level 3. So depending upon the extent of the tumor, most of the time we do the level 1 and level 2 dissections, but level 3 dissection is very extensive, and it goes beyond the axillary vein and behind above and more medial to the pectoralis minor, which is actually a very difficult thing. But most of the time we do axillary clearance of level 1 and level 2 combining with the breast surgery. If you do the simple mastectomy, or you do the modified radical mastectomy, depending upon the tumor, or you do a palliative kind of a surgery in case of the fungating masses. Now, when you talk about the carcinoma of the breast, actually we know that if you talk about a little bit about the anatomy, so we know that there are some ductal cells and lobular cells. So you can see these are the lobules, and there are almost 50 to 20 ducts which are actually coming there, draining from the lobule. So you can see there are multiple lobules, and each lobule has got its own duct, and then duct is draining into the nipple areolar complex. So in the center, you can see that this is the nipple areolar complex, in which these ducts actually they drain, and this breast is responsible for the secretion of the milk under the response of progesterone, and obviously there is inhibiting factor as well, which is a dopamine. So we're not going to talk about the physiology today, how the milk is being produced and what kind of a regulation by the hypothalamus and the pituitary axis is there. But remember that if we talk about in a simple line, if we talk about or define the function of the breast responsible for the milk secretion and some oxytocin release as well. So these lobules and the ducts are important because some of the cancers, they infiltrate the ductal system, which are called as the intraductal cancers or intraductal carcinomas, and some infiltrate the lobular part of the breast. So they're called as the lobular cancers. And sometimes there's infiltration to the skin, and those tumors that infiltrate into the skin, they rarely metastasize. Rest of the tumors which have lymphatic spread, they have a chance that they will be metastasized to the different parts of the body, but most of the time they are locally advanced tumors, and local resection and combining with the radio and the chemotherapy is sufficient to deal with the breast cancer. And also depends upon the stage of the cancer. We'll be talking about this in a couple of minutes. Okay, so when you talk about the pathology, or you can say epidemiological factors which are responsible for the development of these tumors, so we classify these familial hereditary cases and sporadic cases. So familial is like that runs in the families, okay? So that is 15 to 20%. Hereditary is 5 to 10%, like means that gene is being transmitted from one generation to the other generation. So this is actually the hereditary changes, or maybe possible it's not familial, but it's hereditary, like it's like a mutated gene is being transmitted during the developmental processes. Almost 70 to 80% of the cases, they're sporadic. So this is somehow very, very much important, because we actually do not know what causes the sporadic cases, but maybe the environmental factors, the diet we are taking, and the changes in the hormonal levels, secondarily to the cyclical changes during the menstruation and the post-menstruation ages. Now, when you talk about some of the causes, like age is a very important factor. Then we talk about the dietary changes and the diet which is rich in progestin or which is rich in estrogen, and then oral contraceptive pills. Most of the time, these oral contraceptive pills, they have hormones, and under the influence of those hormones, there is the breakdown of a cancer cells within the breast. So that is another factor. Then always ask about if there's a history of familial cancers, like maybe a uterine cancer or a breast cancer or ovarian cancers in the families, because most of the time they're hormonal and they're interrelated to each other. So always ask about these things. So the thing to remember here is this distribution, which is familial in about 15 to 20% of the cases, and hereditary is about 5 to 10, and the sporadic cases are about 70 to 80%. Now, when you talk about the etiological factors, they are more important when you talk about the sporadic cases. So geographical region is very important. Moreover, like it's common in the African Asian population. And then when you talk about the age, usually the postmenopausal age, because there is a withdrawal effect of the hormones, and it's again related to the same hormonal changes. So age is an important factor, usually above the age of 40 years. Then gender, it's more common in the female as compared to the male, and there's a female predisposition of these breast cancers. And although they can be breast cancers can be in the male population as well, but their percentage is very less, and it's a very rare tumor in case of males. Then genetics, we already talked about the genetics in the familial cases. We already talked about the diet, those things which are rich in progestin and estrogen. There are some kind of cereals, and some these dry fruits, and some nuts which have a high content of estrogen and progesterone, that's responsible for the generation of the tumor cells. Then there is some kind of endocrine, you can say mutations, or you can say some pathologies which are related, because breast is an endocrine tissue. Okay, so anything which is changing or causing some kind of changes in the levels of the hormones, that's going to interfere with this tumor as well. And then the history of radiation is very, very much important, right? Because there's a possibility that there was a exposure to the radiation in any form, so that can also lead to these things. So always ask your patient about the family history, about the especially not only the breast cancers, but uterine cancers and the ovarian cancers as well. And then you have to ask about if there is use of oral contraceptives, or there are any kind of contraception being used. And then you will ask about the previous radiation, if there's exposure of the radiation. You're going to ask about the diet as well, because most of the time these are the etiological factors for the sporadic cases. Although genetics and familial cases, they make another category. But when you talk about the sporadic cases, ask about the age, geographical regions, and gender, and if there's any change in the diet for the past couple of months or years, depending upon how the patient presented you, for how long he has been having the symptoms, and ask about the previous radiation.